The perspectives expressed in this podcast are those of the host and guests. The views expressed are their own and do not necessarily represent the views of the National Institute of Health or the United States government.
Hey, Sickle family. I'm Wumi Bakare.
And I'm Dima Hendricks. And we would like to welcome you to the Through the Genes podcast,
where we talk about living, healing, recovering, and exploring curative therapies for sickle cell disease.
We will also talk about our individual curative therapy journeys and the bond that we built as sickle cell sisters.
Episode 4, Transplant versus Gene Therapy with Dr. Caterina Minniti. Welcome to another episode of Through the Genes. I am your gracious host, Wumi Bakare, and I have my co-host.
Hello, everyone. I'm Dima Hendricks.
Today, we are talking to a very special guest, Dr. Caterina Minniti. She is a professor emeritus of medicine and pediatrics at Albert Einstein College of Medicine in New York and an adjunct professor of pediatrics at University of Health Services, Bethesda, Maryland. She was formerly the director of the Sickle Cell Center for Adults at Montefiore Medical Center in New York, and she's also the director of the Red Cell Disorder Center at Children's National Medical Center in Washington, D.C. Welcome to the show, Dr. Minniti. We're so pleased to have you this morning.
Thank you. Thank you for having me. Always a pleasure to talk about sickle cell disease.
Thank you for the work you've done so far. So I wanted to start by asking you a couple of questions, particularly around curative therapies for sickle cell disease. For many patients, we've seen that right before they undergo a curative therapy, they stop the prescription of hydroxyurea, which for audiences who don't know, that is one of the disease modifying therapies. And it's incorporated that they also receive blood transfusions to help to kind of limit how many vaso-occlusive crises that they're undergoing during this time. Can you tell us a little bit about why is that recommendation put in place and what are the effects of hydroxyurea on a curative therapy? Because I've never really understood why they would stop it before starting the clinical trial process.
Thank you for asking me this question. And I think we probably need to step back a little bit to discuss the whole process that leads to gene therapy. Because I think it is not clear, it has not been made clear how complex it is to get from the moment that you and your provider decide that, yes, you are a good candidate for gene therapy, to the moment you actually get the gene therapy. This is a very long process and many things have to happen. Sometimes it lasts 6 months, sometimes it lasts even longer. Now, during this time, there are two things that have to happen. The patient has to be optimized to receive this potentially curative therapy. And we have to make sure that the body is ready to receive the gene therapy. Now, the gene therapy affects the stem cells. So the stem cells is a generic term that means all like mother and father cells of all of our body. But when we talk about stem cells, we only talk about hematopoietic stem cells. So we only talk about the stem cells that make the blood. And so I just wanted to make it clear that that's what we say about stem cells. Now, hydroxyurea, which is the standard of care for treatment of sickle cell disease, affects the stem cells. So it affects the bone marrow. In fact, if you remember, most patients have to go to see the doctor once a month to check their blood because hydroxyurea suppresses the production of new red cells. It's a complicated process by which it changes the way the red cells are made, and there is a process called stress erythropoiesis. During this stress erythropoiesis, hemoglobin F is made, and that's how hydroxyurea works. But it has an effect on the bone marrow. Now, I told you that the stem cells live in the bone marrow, and we need to have them as healthy as possible. So anything that can suppress the production of stem cell is not good, right? So This is one of the reasons why we stop hydroxyurea, not all the time, for some period of time. Especially, we stop hydroxyurea before we collect the stem cells. Now, let me make another step backward. In the past, we used to collect stem cells from the bone marrow, which required the patient having to go under general anesthesia, needle be put in the back, you have to aspirate the stem cell directly from the bone marrow. Yes, it's a painful procedure, but also the most important thing that we found out during the evolution of the study of gene therapy is that the stem cell collected this way were not as good as the stem cell that now we collect from the peripheral blood. So basically, the way we collect stem cell now is with the protocol that looks like erythrocytophoresis. You know, when people get exchange transfusion, most patients with sickle cell disease will remember about the stem cell exchange transfusion. And this is exactly the same. It's like a coin sorter. You know, basically, we take out the stem cells and we put back all the rest of the cells. So we need a lot of this stem cell, as many as possible. And that's why we stop hydroxyurea to allow the bone marrow to make as many good stem cells as possible. Now, it is very important that the stem cells are healthy as possible. You all, unfortunately, are familiar with the fact that in sickle cell disease, usually with age, there is what we call end organ damage. You know, many organs get damaged. The bone marrow is the same.
Okay.
So the older the patient, the less young, is the bone marrow. Even in people that don't have sickle cell disease, by the way, it is much better to have a bone marrow transplant when you are 30 than when you are 50. Mm-hmm. So there is a cellular aging. So anyway, another problem in sickle cell disease is inflammation. So there's a lot of inflammation that is going on in the bone marrow. That's why during the period that before the gene therapy, sometimes we prescribe transfusions. The transfusions are meant to reduce the hemoglobin S for sickle and have the patient having as much hemoglobin A or normal hemoglobin as possible to calm down the inflammation and again make the bone marrow as healthy as possible. And so it's very complicated, but I hope that these two cardinal points are clear. There have to be a lot of stem cells and they have to be as healthy as possible.
So I have a follow-up question to what you just presented. Thank you so much for laying all the groundwork of what happens behind stem cell therapy. We talked about hydroxyurea, but there has not been a lot of mention of the other disease modifying drugs. Do you also recommend individuals that are taking like Endari or Oxbryta? Do you recommend them to stop their medication as well?
That is a very good question. You are ahead of your times, Dima, ahead of your times. The current clinical trials that have been done always in a patient that receives none of the other disease modifier therapies. So at the moment, in the period that goes from the consent to the actual infusion of the gene therapy, patients have not received any other disease modifying therapies. There isn't a strong reason why we could not use them, and I suspect that in clinical practice, most people may continue using, especially therapy such as Endari, which has no effect on the bone marrow, so it really does not affect the bone marrow. Okay. And the Oxbryta or voxelotor, which reduces hemolysis and again doesn't really have an effect on the bone marrow. Crizanlizumab is used for pain crisis. So again, I don't see strong reason not to use it. On the other hand, I have to tell you that we, the community of providers, are really now starting to really codify, like develop a precise protocol on how to use all the drugs that we have in combination with gene therapy. So I personally don't see any reason why not.
Okay.
On the other hand, we most likely will need to use the transfusions anyway, because we do know that the transfusions are the best way of reducing the percentage hemoglobin S and increasing the percentage of A. So there is going to be a period, usually is 1 to 2 months, especially before collection. So before collection is where we need the most stem cells. And the collection, I mean, is when we do the extraction from the peripheral blood, like I said before, of the stem cell that then have to go and be edited, changed, and then put back into the patient. When the cells go back into the patient, it's called infusion. So at least we know the terms like collection, infusion. Infusion is actually the receiving
Mm-hmm.
of the stem cell that have been treated and now are edited.
Okay. I love that you kind of detail that for us because now I have a better understanding of the actual process and the significant benefits of why blood cell, red cell, like, not exchanges, I meant to say blood transfusions are important. But
Mm-hmm.
now, kind of walk us through. You mentioned the stem cell collection process, and from what you've
Yes.
shared, it seems like a very rigorous but detailed protocol. Can you
Yes.
walk us through what the preparation process for stem cell collection is?
Yes. So for stem cell collection, the equipment is remarkably similar to an exchange transfusion. And so for patients that have not had it, basically in stem cell exchange transfusion, we need the two portals into the blood vessel, two tubes, one that takes out the blood and one that simultaneously puts it back in. So the patient will need to have either two very large IVs, or most the time they have what is called a central line, like a portacat that has two lines so that some comes in and some goes out. So some patients have to have that put in. So you're right. That is another procedure, that the patient has to endure. Then we need to give a medicine called plerixafor. This is a medicine that stimulates the stem cells from getting out of the bone marrow. It's actually something that removes the glue that keeps all the stem cells in the bone marrow and have them unstick and go in the periphery. Sometimes patients that receive this procedure experience some pain, like muscle pain, bone pain, because remember, these cells are leaving the bone marrow and going in the peripheral. And so there is some pain associated. And during the gene therapy trials, sometimes patients have pain crisis around this event. Now, the pain crises are much less if the patient had been on exchange transfusion before, so that they don't have enough S to have a vaso-occlusive crisis. So again, I go back to the need for exchange transfusion. So they're going to have this line placed. And then after they get this injection, which is like a sub-Q, is under the skin, this injection, we wait the 6 8 hours, and then we start measuring how many stem cells are in the peripheral blood when the moment is right, which is usually within 1 day. Then we do the exchange transfusion and remove. Now, unfortunately, often the first collection does not have enough stem cells. I told you we need a lot of these stem cells. And so it does happen many times that the patient has to do this thing twice. Okay, so the extraction of the stem cell twice in order to have enough stem cells that then go through the rest of the process of altering the genes and then have enough cells to go back. As patients age, and again, I'm fixated on this age because unfortunately it is important, the stem cell collection gets a little bit less efficient. And so when you look at these clinical trials, you will see that they're all young people. If you can see that the mean age is 25, 27. And so these are young adults because clearly in that age, it works best. Just because the bone marrow, as I said before, is healthier, you can find more stem cells and it's easier, to do the whole thing. And that's why everybody's trying to go down with the age of gene therapy. So we are trying to offer younger and younger people where we know the outcome is most likely better.
So the FDA approval was on December 8th, as you know, 2023.
Yes.
And a lot of questions patients brought up was one, the price, the price tag associated with this curative therapy, and two, the time commitment. So what I want to hear from you basically is, what is the timeline for the preparation of the stem cell process?
Yeah. So the time, it is a very time consuming procedure. So I think, you have to bank on 6 months. It takes months. It's not in weeks. It is in months. Now, the actual preparation of the stem cells once they are collected is not particularly long. It's a couple of weeks. So, after 3-4 weeks, you can get your process reinfused.
Mhm.
So and it is a time that is always changing and getting better and better. And I predict that the more gene therapy procedures will be done,
Mhm.
the shorter will be this time, because it will be, it's constantly being improved and automated. So I know that they're working very hard in making this process more seamless and automated and simpler, so that it is shorter, but it's going to take at least 3-4 weeks.
Okay.
And during that time, the patient is best if he doesn't have a pain crisis, because you understand that you don't want to reinfuse the precious stem cell in the middle of a pain crisis. So it's important that the patient is kept as free from pain crisis as possible. So sometimes people have restarted the hydroxyurea, when it's a longer period of time. Other times, some doctors prefer to keep them on transfusion just to prevent having a pain crisis, because the process doesn't work well in the middle of the storm
Mm.
that it is a pain crisis. I've seen that even if a patient has a little virus, it's not as good. It doesn't work as well as when the patient is perfectly fine, steady state.
I think that's important that you shared that, because for a lot of audiences, I think when we're giving this timeline, we tend to restrict ourselves and be fixated on it. But I know in my case, my clinical trial ended up running longer than we had anticipated. A couple of the dates had to be moved back because you need to make allowances for certain things to happen. Maybe the patient needs another red cell exchange. Maybe you need to extend the period because they need 2 or even 3 rounds of this.
3 rounds, and you're right. You're right. Sometimes 3 rounds, or sometimes the product is not as good. There are so many unknown, and I am confident that they are gonna get better and better, with time. But at this time, it's a bit unpredictable.
Sure.
And plus, each patient is different.
Yes.
Some patient may collect 10 millions right away, and some people don't.
Before we get into manufacturing, I wanted to ask this question. We mentioned the issue of age and things happening to patients. Who is the ideal patient coming into the clinical trial? Because you have to be sick enough to get the gene therapy, but you can't be too sick that it would do something to your body or it will fail. So it's like you have to. It's like a tightrope. Who's the ideal?
You're right. Yes, you're right. It's like Goldilocks, too little, too much, just right. And so the ideal patient is a young person, I would say under the age of 35, but over the age of 12, because, it's not been tested, that low. So between 12 and 35, maybe 40, but I would say ideally, younger, who has a lot of pain crisis or acute chest, but has been able not to have other end organ damage, such as severe renal disease, severe liver diseases. So hopefully somebody who either has not been transfused too much, because with transfusion we have iron overload, the liver gets damaged, and doesn't have too much CNS disease. By CNS disease, I mean stroke. Now, in those trials, we try not to enroll patients that had the extensive stroking, especially something called moya moya. Moya moya, it's an abnormality of the blood vessels in the brain when there is an area that gets very ischemic, there is no blood supply, the body makes a lot of smaller blood vessels by angiogenesis that are very fragile and can break. Anyway, about 20% of patients with stroke have this moya moya, and we are concerned that they could stroke during the process. So patient with silent infarct or maybe an old stroke, they're definitely a good candidate, but nobody that is on dialysis, nobody who has had severe liver damage. So the current trials have had as endpoint pain crisis. So I think that's important to notice that both gene therapies were tested with the primary goal of reducing pain crisis. So even though we all know sickle cell disease has a lot more complications, right, than pain crisis, at the moment, what we know for sure is that patients don't have pain crisis. Now, we don't have enough information to know if the rest of the sickle cell disease complication will be improved or reversed. And reversing is very hard.
Mm.
But at least improved or stabilized. And so there are many things we don't know yet about the rest of the complications. So I have to still focus on patients that have a lot of pain.
You emphasized the health of a patient, but this is a recurrent question in the patient community, is that for right now, is gene therapy only approved for people with hemoglobin SS, or are there some selective criteria for people with other types of sickle cell
Yes.
disease?
Yeah, it's a very good point. It's approved for S beta 0, S beta plus.
Okay.
Now, in the actual approval, in the label, is written sickle cell disease. Actually, I don't think it specifies, but I can tell you that in the clinical trials, the patient that have received were either SS or S beta 0. That leads to a very important distinction. Not all gene therapy are the same, right? Of the two approved gene therapy. So one of the gene therapy approved, the CRISPR-Cas, the Vertex one, increases hemoglobin F. So the way it works is by increasing hemoglobin F. We know that hemoglobin F is very important in sickle cell disease in mitigating the complication of sickle cell disease. But we have a lot of data on hemoglobin F in patients with SS, S beta plus, S beta 0. The role of hemoglobin F in SC has not been explored that well yet, even though I wrote a paper on that,
Mm.
and I postulated that it would work as well as in hemoglobin SS. So me, myself, I think it should work. At the moment, no gene therapy has been done in a patient with SC in increasing the hemoglobin F. The other one, the lentiglobin virus vector, the one from Bluebird Bio,
Mm.
acts in a different way. It adds a hemoglobin A that is being modified to be a little bit like hemoglobin F, but it's really not hemoglobin F. It has anti-sickling capabilities. Again, it has not been used in hemoglobin SC. And I don't know at this time if physicians would be so eager to recommend it for a hemoglobin SC yet.
Okay.
So I think the first wave is going to be patient with SS as beta zero with a lot of pain, quite young, and a pretty healthy kidney, brain, and liver.
Mm.
Okay.
And that's the way it should be. Every time there is a new therapy, you always try to minimize adverse events. Think about if we do it in a patient that has severe, some renal disease, and then the kidney completely shut down. I mean, that would be horrible.
Mhm.
And so I do think that we're gonna learn a lot by applying to real patients, because the patient clinical trials are really handpicked.
Mhm.
So it's when we see real patient that we need to learn, and that's why we advocate for having some way of following up all of the patients so that we know what happens in the real world to the patient.
I don't want to take up a lot of your time, but before you go, I do want to talk about the manufacturing process. And so what I was mentioning earlier, Wumi and I both went through our journeys, but we didn't know what was really going on behind the scenes. Could you explain the manufacturing process for warriors who are going through the gene therapy process?
Yes. So as I said, that we're gonna first stimulate the production of these cells that are called CD34. Just for you to know, you might hear this term CD34. So just for you to know, CD34 is the name of an antigen, something that sticks on the surface of the stem cells that identifies them as stem cells. So that's how we collect them. We find the one that have this thing sticking out, and we pick them out. Right? So we pick them out, the CD34 positive cells. And there are other antigens, it's a little more complicated, but for simplicity, I think that's enough. And then they are frozen, and then they are sent to a facility, which, there are not that many facility, in the world that can do this process. And each company has its own facilities, and in these facilities they are electroporated, which means the membrane of the cells is broken and the nucleus is kind of opened up temporarily, so that either the lentivirus vector or the other vector that takes the CRISPR-Cas9 enters the nucleus, right? And so that they can unload, the genes, and so that the gene can go in the genome, in the DNA of the patient. Then they have to have a lot of testing. One, to make sure that the stem cell is still working. Two, to make sure that they didn't get infected. Three, to make sure that there weren't, random pieces of DNA, stuck someplace. And then once all this testing is done, then is shipped back to the place where the patient was originally, admitted to the hospital. And it really looks like a blood transfusion.
Mm.
It gets reinfused like a blood transfusion. So actually, it doesn't look, particular exoteric
Mhm.
when it's reinfused in the patient. So the actual infusion is not a big it's anticlimactic. I think you think, well, you know especially sickle cell patients, receive transfusions all the time. So I don't know, Wunmi, how you felt when you actually,
It was very underwhelming, to say the least, because
yeah.
here the science nerd in me was so excited. I thought I was going to be, this was X-Men. I was going to be a mutant.
Yes.
And then on like day zero, I was just like, that's all? No pomp and circumstance?
Exactly.
Yeah, it's,
That's right. I think,
Oh,
yeah, it's all this hype, and then it's just a blood transfusion. So, as you can understand, all this process, freezing, unfreezing, treating them, putting things inside, can damage these stem cells. So, we lose some stem cells in the way, right? So it's not the same number when they come back. Some, don't make it. And also we want to keep half of them frozen in case something goes horribly wrong and you need to reinfuse the patient his own stem cells. So, these stem cells are divided in at least two pots. One pot gets transformed, transduced, prepared with the new gene. The other one is kept as a safety so that if something happens, God forbid it doesn't work, it gets lost, it gets broken, whatever, it doesn't engraft, then you can always infuse back the bone marrow, the patient, its own bone marrow. Yes, they're not going to be cured, but at least, the patient will be okay. So.
Um, we had earlier in the conversation, we spoke about gene therapy versus stem cell transplants. Can you,
Yes.
for me, compare and contrast gene therapy, stem cell transplant, and bone marrow transplant for the audience? Because sometimes there could be a little bit of confusion.
Mm-hmm.
Yeah, no, you're right. Bone marrow transplant and stem cell transplantation are the same thing.
Mm-hmm.
Okay, so they were called initially bone marrow transplant because we were actually taking the bone marrow out of the bone marrow. But nowadays they're called more genetic stem cell transplantation. So stem cell transplantation, bone marrow transplantation, same thing. The main difference is that in stem cell transplantation, you get the bone marrow or the stem cell from another person, right? So it's not it's from another person. Now, when this person is a matched sibling, which means a brother or sister that are perfectly matched, those are the ones that have the best results altogether. So that's the main difference. Instead, in gene therapy, is your own stem cells that are taken out, modified, and put back in. The chemotherapy treatment is very similar. In the bone marrow transplant, there are additional steps taken to make sure that you don't have what is called graft versus host disease. Because since you are receiving the stem cells that are not yours, your body says, who are you? And they try to kill them. So we have to do a little more to avoid that the stem cell are rejected. You will hear this term rejection. And then there is another type of bone marrow transplantation or stem cell transplantation in which we call it haplo, which means half, and where you have as a donor, your mother, your father, somebody that is not 100% matched, so is half matched. Unfortunately, those ones tend to be rejected a little bit more, and they have, more issues with morbidity and mortality than the gold standard, which is a sibling match. The reason why we don't do this for everybody is because so few people have a good match. It's estimated 18%, 18% of patients have a full match, brother or sister. They have to be from the same mother and the same father, and they have to match. Okay, so the gene therapy was thought of, has been developed exactly for that reason, because so many people don't have a match. So it's your own cells. Now, that is a good thing because you don't get the graft versus host disease, but also can be a not so good thing because the stem cell of the patient may already be a little bit damaged. I don't know if you have heard about those 2 cases of leukemia that happened. And and that was in the first group of patients that received the lentivirus vector. And so I think it's important that everybody is aware of this potential complication. And in fact, the FDA put a black box on the Bluebird Bio and said it may cause a leukemia. And and I do think it's important that we talk about it so that people are really aware of all the potential complications. It is true that we have not seen a leukemia with the CRISPR-Cas. We have not seen it with the later version of the vector and the treatment. And I can tell you, to end on a positive note, that there is a lot of work being done trying to overcome the two major problems of gene therapy. One is the need for chemotherapy. So there are many people working different techniques to avoid the chemotherapy altogether, because we think the chemotherapy has a lot of negative effects, and one of them also could be that it could be stimulating, this leukemia, kind of, the more chemo you have, the more event you could have. So it would be great not to have the chemo. And the other one, which is, the goal is to have it in vivo. In vivo means that you don't have to take the cell out, manipulate them, and put them back in, but just ideally just give an infusion. The underwhelming experience that you have, just do that and have the stem cells find their way to the bone marrow and repopulate. So these are the two goals, the two major issues that researchers are working on, trying to make gene therapy really, really available to a lot more people than it is now.
Thank you. I feel like the science nerd in me I'm completely educated, but more importantly, the way you have broken things down,
Oh, thank you.
genuinely feel like I'm walking away for this interview learning at least 10 things, 10 different things, because you've spoken.
That even two things is enough.
Good.
Notes.
And thank you. Thank you. It's a very complicated. I can tell you, many doctors don't understand it. That's a secret. Oops, I'm on a podcast. And that's why it's very important that you, the patients, are educated about it, because it's really complicated. It's really complicated.
Now I can see why Dr. Minniti is dubbed a clinical trial specialist and a translational researcher. She has answered so many questions, educating us about research for people living with sickle cell disease. Now, get excited to meet our next special guest, Genesis Jones.
So allow me to introduce Genesis Jones. She is a sickle cell warrior, survivor, advocate, student, and speaker. She does all the things. She's even a 2-time author. You can find her book, Resilient and Rebirth, on Amazon. So let's welcome Genesis Jones.
Hi.
Hi, welcome to the show.
Hey. So we have so many questions for you as it relates to your curative therapy journey. The first thing is, let's tell me life before your curative therapy journey.
Yeah, so I was born with sickle cell SS, and growing up I was in and out of the hospital. So I had my first major crisis at the age of 8, and that's when I had my first silent stroke. And I think that was a pivotal moment for me and my family, because we knew that this was a very serious, not only disease, but it was something that we had to really take hold of. And at the age of 8, I had my first silent stroke. And then shortly after that, I had another one at the age of 10. So when I was at the age of 8, they put me on blood transfusions, and I was on blood transfusions for about 8 years. And for 8 years after that, I started hydroxyurea to continue to manage my sickle cell. All throughout that, I was still in and out of the hospital trying to manage my pain. And I think that was the hardest part, just managing the pain, doing school, and trying to live a normal life. And I think that's when the mental health aspect really hit me, because I just felt like there was no escape from my pain, and I was really going through a bout of depression throughout my adolescent years as well.
Now that you've given us kind of a background context of your story growing up with sickle cell disease, can you share with us what was what ins I want to use the word inspired carefully, but what motivated you to
Mm,
want to pursue a curative therapy? Because um, there are different options,
mhm.
and not everyone chooses that, particularly if they're on a disease modifying therapy like hydroxyurea, and if that medication does work for them. So, what led you to want to be curious enough to say, let me embark on this journey to participate in a transplant?
Yes, so it wasn't something that actually was motivated. Um, when I had my first silent stroke at age 8, they put me on the registry, the Be the Match registry.
Wow.
And all through those years, they were trying to follow up and look at for a match. When I transitioned over to the adult side, I kind of lost track of where I was on the registry. And at that time, I didn't know there was such a lack of diversity on the registry. So I didn't understand why I never got that match. So when I first met somebody with Be the Match in 2019, they invited me out for an event, and that's when I somebody heard me speak that had a contact there at NIH, and he told me about the things that they were doing for sickle cell, and he thought that I would be a great candidate and gave me a contact. And that's when I reached out, and they flew me and my family out for a bone marrow screening. So that's the first time I found out that my mom was a perfect half match. So it was kind of just, I think, God driven. I didn't really wasn't seeking it. It was something that kind of fell in my lap. Because all throughout that time, my pain was just getting worse and worse. And I knew that there was something, I just couldn't have a good quality of life that I needed to sustain the things that I wanted to continue to do.
As you were about to embark on this new journey, you found out that your mother's a match. What were the challenges that you had to face while going through this transplant journey? What were your challenges and how did you navigate through them?
Yeah, so there were financial burdens as well as still physical burdens because the NIH, or the National Institute of Health, is in Bethesda, Maryland, and I live in Dallas, Texas. So of course, it was making sure that we were going to be able to have our household sustained for that 6 month period. And then my grandma, who we had to have a caregiver during this time frame, so she had to essentially quit her job. And that was something that we had to make sure we were going to have financial, sustained financial during this time. So we had to have things that were in place for like GoFundMe. Our church helped out, things that were coming together to make sure that we were going to be able to have a sustained process throughout that transition in that period of time.
Thank you for highlighting the financial cost, because I think one thing a lot of people don't realize is even though the National Institutes of Health provides a clinical trial that is free, you also have to recognize that not all patients live in the Bethesda, Maryland area. I know I had to fly from Seattle there, so it was um, a significant financial cost to our family, because you also have to
Mhm.
realize if you're out of work for that period of time, and you're leaving people at home, what responsibilities at home are you going to have to manage while you're away? So thank you for highlighting that, because I think a lot of times when people hear clinical trial, they assume it doesn't come with any cost. And the reality is there are miscellaneous costs each and every day, whether it's transportation, because you are on a fixed stipend. So you
Mhm.
kind of have a financial limit that you can um, embark on each and every day. But now, kind of talk me through the pre part of your transplant. Can you share with us what type of transplant did you participate in, and what were some of the things that you had to go through prior to your day zero?
Yeah, so I went through a half match, so a haploid identical transplant. And like I said, my mom was my donor. So we started in 2019, and we flew out in January 2020 to start my pre-transplant appointments. And that process took about 2 months. And when I say appointments, I'm talking about like a head to toe workup of looking at your body, as well as the donor, as well, to make sure that you can undergo the transplant experience. So they did hit like my eyes, my heart, everything, to make sure that I could sustain the transplant itself, because it's a very invasive process, and that was 2 months. And I had to make sure that I also went through fertility preservation before that process, as well as what else? The fertility was the hardest, and that was the biggest thing because you had to do that before the chemo.
Can you talk to us about that a little bit? Because I
Yeah.
think a lot of times when we talk about curative therapies, people don't realize you undergo something called a conditioning regimen, and that
Mm-hmm.
is to completely wipe out your bone marrow so that there is a higher chance of your body not rejecting the new donor cells. So,
Yeah.
talk to us a little bit about the fertility preservation for you. How old were you at the time? And how many rounds of IVF did you have to go through, or cryopreservation?
Yes. So at the time I was 21, and I was luckily that NIH had a program where they partnered with Walter Reed, so I can have the uh, fertility preservation, at no cost at that time. It was through the program. So I went through one round of the egg retrieval, but of course I had to do it was 2 weeks of the shots, that added up to making me be able to go 2 weeks of appointments, but I was a whole month of shots that I had to do to make sure that I was getting enough of the eggs before I did my egg retrieval at the end of the month. And that was very lonesome, very invasive. I remember telling my grandma, I don't have issues with shots, but it just was something that I had another thing I had to do, and it increased my pain as well, my sickle cell pain, because throughout this pre-transplant, you're still having sickle cell, you're still managing your pain that you're going through. So it was a lot to have to go to the appointments, make sure that you're getting your eggs um, collected, or they're doing the process, and I just remember it being very tiresome.
Now, I can recall my experience, and I'm just getting flashbacks while I'm talking to you. That IVF process is absolutely grueling on the
Mm.
body, especially for warriors. So kudos to you for just going through that. So how long exactly was the conditioning process? Just walk us through the next step.
Yeah, so I finished up the fertility process, and then the I started conditioning, and the conditioning is about a month and a half,
Mm.
because you have to do chemo, and that is about 2 to 3 weeks. You take oral and IV chemo, and then while you do that, you are still going to appointments to make sure that your body is depleting your cells. I got what is it, where they take out your sickle cells. Uh, uh, um, I can't think of the word. Apheresis.
Apheresis.
Yes, I got apheresis to make sure they depleted all my sickle cells as much as possible, so they can make room for my mom's cells before. And then I got radiation 2 days before I got my mom's cells. So those are the conditioning, and then that's it.
So
Um,
I have a follow-up question, because you're
yeah.
talking about going through all of these things,
Mm-hmm.
fertility, the IVF, the radiation. apheresis. That's a lot. Were there any tools or was there anybody to guide you mentally through this process?
Yes, so I did have a therapist or somebody that I connected with before this whole process started, and we were meeting bi-weekly to make
Mm.
sure that I was, okay with the process, how I was feeling, um, how I was managing with my pain, and I think that was very important. And when things got harder afterwards due to stuff, I think it allowed me to really have that bond continue to grow throughout the transplant. So that I think that is important. I think that should be sustained even longer after the transplant is over. So yes, there was somebody there.
On the next episode of Through the Genes podcast, we continue our conversation with bone marrow transplant recipient Genesis Jones alongside Winona Coles, the research lab manager at the National Heart, Lung, and Blood Institute.
Yes.
So I have a question for both of you ladies. As I'm listening to you guys talking about the chronic pain, and Genesis, with you talking about the complications post-transplant, I want to know, for someone who the transplant didn't work for, the curative therapy did not work for me, I didn't get that far into the process. Was your curative therapy journey, was it worth it? Was all of this, going through the complications and still feeling pain, was it all worth it?
Through the Genes is funded by the National Human Genome Research Institute, part of the National Institutes of Health, through the Democratizing Education for Sickle Cell Disease Gene Therapy Project. Don't forget to follow Sickle Cell Prodigy and Through the Pain Inc. for additional resources and initiative updates. Thank you for tuning in to this episode of Through the Genes.